From the JAMA Network, this is JAMA Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinion featured in JAMA.
This is Dr. Preeti Malani, JAMA Deputy Editor and Professor of Medicine at the University of Michigan. Welcome to this JAMA Author Interview. I'm joined by Dr. Thomas Lietman from the University of California, San Francisco, where Dr. Lietman is the Ruth Lee and Phillips Tygeson Distinguished Professor in the Department of Ophthalmology and Department of Epidemiology and Biostatistics, and the Director of the Francis I. Proctor Foundation. He is the author of a study titled Mass Azithromycin Distribution to Prevent Child Mortality, which was published in the February 13, 2024 issue of JAMA. Welcome, Tom, and thank you for joining me today.
Thanks for having me.
So azithromycin is a commonly used antibiotic. It's a drug I most often prescribe for pneumonia, but azithromycin is also used in other ways. Your past work has focused on mass administration of azithromycin to eliminate trachoma. Similarly, mass distribution of azithromycin has been shown to reduce childhood mortality in some settings in Sub-Saharan Africa. And to that latter point, this reflects work you and others did several years ago. The Mortar trial, published in 2018, found that twice-yearly distribution of azithromycin reduced all-cause mortality in children aged 1 to 59 months in Sub-Saharan Africa. But this effect varied in the 3 study countries where the Mortar trial took place, anywhere from 3 to 18%, suggesting that the intervention may not be effective in different geographical areas, time periods, and conditions, which brings us to the current study, the Community Health with Azithromycin Treatment, or CHAT trial, which was a cluster randomized placebo-controlled trial evaluating the efficacy of single-dose azithromycin for prevention of all-cause childhood mortality. The CHAT trial was conducted in Nona District, Burkina Faso, which is in rural northwestern Burkina Faso. Participants were children aged 1 to 59 months, living in the 341 study communities, and community was the level of randomization. A little bit about the geographic area where the CHAT trial occurred. In addition to high rates of childhood vaccine coverage and universal access to healthcare for children under the age of 5, seasonal malaria chemoprophylaxis is used in this area. So with this extended background, can you please briefly tell us about the CHAT trial? What was done and what did you find?
I'd be delighted to. First of all, this was an enormous effort. Hundreds of team members with the Burkina team led by Dr. Ali Sieh and the UCSF team led by Katie Oldenburg and Elodie Labat. The earlier trial that you mentioned, Mortar, found that azithromycin reduced childhood mortality overall, but as you pointed out, the results suggested some heterogeneity in effect. Some have interpreted this to mean that the intervention might not be as effective in areas with lower mortality, areas outside of Niger. And others have suggested that azithromycin wouldn't be effective at all if given concurrently with seasonal malaria chemoprevention, because that also has a relatively broad spectrum antibiotic in it, sulfadoxine. So in the CHA study, we were retesting azithromycin distributions in an area outside Niger, lower mortality, and where that seasonal malaria chemoprevention SMC was also being given. There were 341 communities in the Nuna district of Burkina Faso that were eligible, but due to security concerns, we could only get to 285. So the study was already a little bit smaller than originally intended. Communities were randomized to either azithromycin or placebo, with the children 1 to 59 months of age receiving 6 biannual distributions, so over 3 years. And mortality was monitored over the 3 years by a biannual census. So that is, if a child was present on one census and then not present on the subsequent census due to death. So this was a very large trial, but very simple intervention and outcome. The results, just to jump to the results, we found an 18% reduction with azithromycin compared to placebo, although the confidence interval for that estimate was pretty broad.
So an important point that we worked together to emphasize in the paper is that the mortality difference between treatment and placebo communities did not reach statistical significance. As you note, there was a wide confidence interval. So one interpretation might be that this is a negative trial. An alternative explanation is that the study was not adequately powered. And you mentioned that because of the geopolitical issues in the area, you couldn't actually get to some of the communities that you had hoped to include in the study. How should the World Health Organization and other groups use the results of the CHAT or CHA trial?
You're exactly right. The p-value was 0.07, so it was not statistically significant. It's difficult to say whether the result was due to chance alone or just not enough power. Regardless, it is another data point to help stakeholders evaluate the intervention. I found it very encouraging that the point estimate of the 18% reduction was identical to that found in Mortar, Niger, even though the mortality rate was less than half as high and the communities were already receiving SMC. So I think it's useful in combination with the other studies, both the ones that have been done and then some other ones that are going to be coming out in the next year or two. There's the Avenir study in Niger and the Lakana and Sante studies in neighboring Mali. And one example of how these may be stronger together than individually, maybe in some of the secondary analyses. For example, Mordor found the greatest benefit in the younger children, those under 1 year of age. And the Shah study here found greater benefit in the older kids, 2 to 4 years of age. If you average these, it's a pretty similar effect across ages, which I suspect is the truth. And the reason this is important is that the WHO currently recommends restricting the intervention to only children under 1 year of age, in part to reduce selection of antibiotic resistance, but also in part because Mordor showed the greatest effect in this age. If it's equal effect over all ages, that may need to be reconsidered.
What do we know about the mechanism of action for azithromycin? How does azithromycin reduce mortality?
That's a great question, and a lot of people have asked us that. The obvious is azithromycin is a broad-spectrum antibiotic, so presumably it's by its antimicrobial effect. The leading causes of childhood mortality in this area are respiratory disease, diarrhea, dysentery, and malaria. And all three of these were significantly reduced in the Mordor study, for example. Now, with trachoma, an eye disease that does not cause mortality, but where we do use these mass azithromycin distributions, we know that repeated distributions give us a herd-like effect in a community. So even those who aren't directly treated can receive some benefit, much like herd immunity with vaccination. So we believe that azithromycin mass distributions may be working by reducing pathogens in the entire community rather than just happening to treat a few children who are sick at the time. And one other sort of mechanism, these are door-to-door distributions, which are a good way to reach the underserved who may not have great access to the healthcare system. As an example, in Mordor, by far the most benefit, the largest reduction in childhood mortality was found in the communities farthest away from the health post. So while we believe azithromycin is preventing infectious disease, the mass distributions may be doing so by reducing community burden of pathogens and by reaching the most vulnerable populations that don't have great access to healthcare.
Do we know anything about antimicrobial resistance and any harms that might come from giving azithromycin to so many people?
That's the real constraint here. And whenever we talk about this study, we have to bring that up. We've collected a large number of nasopharyngeal and rectal swabs from the Shah study and are just starting to test them for resistance. But we know from earlier studies that we are selecting for macrolide-resistant strains of bacteria. And we almost certainly will find that in Shah as well. The WHO and ministries of health are going to have to balance the benefit of the reduction in mortality versus the risk associated with resistance. Now, remember, trachoma programs have been distributing azithromycin to entire communities for decades. So Niger, Burkina Faso, and other countries are quite familiar with the intervention. Trachoma programs give out about 3 times as many doses per year as the childhood mortality programs because they treat all ages, not just the preschool kids. In trachoma programs, we found that resistance gradually disappeared after the distributions were discontinued, so that's encouraging. And lastly, in the past, we haven't found great evidence for co-selection of resistance to other classes of antibiotics. For example, if the distributions increased resistance not just to macrolides like azithromycin, but also to beta-lactams like amoxicillin, that could have an enormous implication.
Is there anything else you'd like to add about this study?
This was interesting to us because these studies are getting quite large. They have to be rigorous, masked, and randomized, but they're also public health programs in themselves. They're just enormous undertakings. And I know the Burkina team, as I mentioned, led by Dr. Ali CA at CRSN, was pleased with the results scientifically, but he was equally pleased with the benefit to the communities. So there's a type of trial which is actually also a public health program in itself. And I think this is just starting to get there.
Dr. Tom Lietman, thank you for joining us.
Thank you very much.
To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.